Well, good afternoon, ladies and gentlemen, and a warm welcome from the Pelvic Floor Foundation of South Africa to all present. There are many people that have taken the trouble to log on, and that's because we've got Tina Wojno and Dzień dobry, Tina.
Dzień
Dobre don?
dobry.
Dzień dobry. Well, you know, Tina and I speak Polish, but I don't think many other people do, Steve. With me here is Steve Jeffrey, Professor Steve Jeffrey, and my name is Peter de Jong. And it's a great pleasure to have so many people with us this afternoon. The microbiologist of Tina Wojno is the head of department of the microbiological laboratory at Lancet. She's taken over from the late Dr. Judy Whittaker. And Tina has a great interest in women's health. And then she's speaking this afternoon on Actinomyces, on gynecological test results. What next? What next indeed? Now, Steve, we have a sponsor this afternoon. You're familiar with them. This is Metagenics, Steve.
Yes, absolutely. Metagenics. And it's a great pleasure to have Belinda McFerrin, who's one of their marketing team. Belinda, you were going to just share like 3 or 4 slides with us. And I thought we could do that right away, Pete.
That's fantastic.
Hi, thank you. Okay, yes, I'd like to share a few slides. I'm Belinda from Metagenics. I'm the rep in the Western Cape, and I'm really excited. Thank you for the opportunity to be here. So I'd like to start with just briefly, what is Metagenics? So we're a brand of nutritional products with unique, highly bioavailable therapeutic formulas that are backed by research. But today I'd like to discuss 2 of our urogenical formulas, Ultraflora Women's and Uridine. So I'm sure that you are all using probiotics already. So I'd like to highlight a targeted probiotic which offers urogenital support and maintains gut health. So Ultraflora Women's is a combination of 4 probiotic strains at 4 billion CFU per capsule. I'd like to start with the 2 strains, L. rhamnosus RG1 and L. reuteri RC14. These 2 strains have got a lot of research for helping to restore healthy vaginal microbiome. So that happened in 6 weeks in this one study I'll show you now. And it also lowers the risk of bacterial vaginosis and yeast infections. So I'd like to start with this study. It was done on bacterial vaginosis and other vaginal infections. It was the 2 strains I just mentioned versus placebo. It was a double-blind randomized placebo-controlled study with 544 patients, and it was done over 6 weeks. At 6 and 12 weeks, patients underwent a gynecological exam and vaginal swabs were taken. At 6 weeks, there was a significant improvement in the treatment group versus placebo. But what I liked about this study is they stopped taking the probiotic at 6 weeks. And at 12 weeks, many patients still had a healthy microbiota, a vaginal microbiota. So the conclusion of the study was that probiotics could be a safe, side effect-free treatment for one of the most common conditions in gynecology, bacterial vaginosis. Then I'd like to look at the remaining 2 strains quickly. So L. plantarum LPL33 and B. lactase B12 have got research to improve a healthy gut and relieve gastrointestinal symptoms. So yeah, I'm going to focus again on one study done on LPLA33, which was published in the Journal of Gastroenterology. It was a double-blind, placebo-controlled, multi-center study with 307 patients. They were divided into 3 groups: placebo, a 1 billion CFU, and a 10 billion CFU. And the results were that there was a significant improvement in IBS, as well as perceived stress in both probiotic groups compared to placebo in a dose-dependent manner. So Ultraflora Women's is the ideal formula for patients struggling with urogenital and gut issues, and the dosage is 1 capsule daily.
Right.
Then I'd like to mention Uridine as well, if that's all right. So Uridine is for UTIs, and this is an issue that impacts many women and can have quite a severe impact on quality of life. So Uridine contains the 2 ingredients, cranberry and D-mannose, and those address the infection in the bladder. But what makes Uridine unique is the addition of your quercetin, your HMOs, your green tea, and your vitamin C. So your HMOs in your green tea get rid of the pathogens, the pathogenic bacteria in the gut, which is quite often causing the reinfection in recurrent infections in ladies with recurrent UTIs. Another thing that your other ingredients do is they help to break down the biofilm that the bacteria hide from the antibiotics. So they're really addressing a lot of the causes of recurrent UTIs. So the dosage for Uridine, if you're using it in an acute situation, is to take 4 tablets daily for 7 nights with plenty of water. And if you're using it preventatively, it's 1 tablet at night. And that's my story. If anybody would like any more information on any of the Metagenics products or would like to see any of the research, please contact me. My details are on the screen. Thank you.
Thanks, Belinda. Yeah, it's a very important topic, Steve. Gut biome. Did you see the latest Journal of American Medical Association came out 4 days ago on the association of gut biome and cancer therapy in cancer of the gut? And one of the new modalities is the old modality of fecal transplants. So if anybody shows any interest in that, please just go to the JAMA, and it's about 4 days ago, and click online and they'll give you an update on that. So ladies and gentlemen, it gives me great pleasure to introduce once again Tanya Wojno, and microbiologist at Lancet, Actinomyces on Gynae test results. What next? Thank you, Tanya. Tina?
Thank you so much. Thanks. It's great to be here. And thanks once again for the opportunity and the invitation. And thanks, Belinda, for your very interesting products. I just wanted to mention the Uridine has also got the D-mannose, which I also read quite a lot of papers on with the it actually D-mannose is excellent to prevent the commonest cause of UTIs, which is E. coli, and it actually prevents the E. coli from sticking to the barrier of the lining of the urinary tract. So it's also it works very, very well. There are a lot of papers on that as well. Just my little 2 cents worth there. Okay.
Maybe we can just ask Chris to get
Share the
Tina
slides.
to share screen and
Yes.
then get the slides on as well.
I'm going to do that right now. Can I share my screen?
Yes. So,
I'm
Belinda,
just
would you mind just
replacing.
How
stop
do
share?
I unshare? How do I unshare? Oh, yeah, stop share. Okay, got it.
Just touch stop share.
Okay, there you go.
Perfect.
Okay, can you see my screen? Is it
We
full?
can, thank you.
Okay,
Loud and clear.
perfect.
It-
Thanks. Okay, so I was chatting to Chris and thinking of a topic. Initially, we were going to discuss microbiome. It's another little pet topic of mine. But I thought something that's quite topical is Actinomyces, which I do get frequent requests about, just in terms of how to interpret the test results. So although it's not very common in terms of actually causing disease, it is a common finding on a test result. So just I wanted to go through with you in terms of when to worry and when not to worry, because I do get this this question quite a lot.
Tina, can
yeah.
I just say, if you press Alt F5, you'll go into full screen. Right now you're in
sorry.
present two.
Okay,
Yeah.
let's do that. Alt F5. Alt F5. Okay, it's not working. Let's try something different. Just go into display settings.
Okay, good.
Is that
There
better?
we go. Perfect.
Okay.
Perfect.
All right. I'm not that challenged when it comes to IT stuff, although I am a little bit. Okay. Let's see. All right. So we'll go through a little bit of microbiology, not to bore you at this hour. We'll talk about some epidemiology in the pelvic scenario. We'll go through a few clinical scenarios, and then we'll go through treatment, and I'll go through a case study as well. So Actinomyces is actually a branching filamentous gram-positive bacillus, and they're quite obvious to see under a microscope because they do look like little branches. We grow them best under anaerobic conditions, and some doctors will forget to ask for Actinomyces culture specifically. However, you know, even though you don't really ask for anaerobic culture, we will grow these organisms anyway because they're facultatively anaerobic. So that means that although they prefer an anaerobic environment, they can grow under a semi-anaerobic environment in our normal setting as well. They can take a little while to grow, so it can take up to 2 weeks to grow. But we do generally see, so the colonies are quite funny looking and they look different to our normal organisms. So we do, you know, when we see them, we can see them quite, because they look quite different. There are quite a lot of different species, and a lot of the other species are not very virulent, and they don't have a very high risk of infection because remember, they are part of our normal flora. However, the ones that are attributed or cause infections are usually the Actinomyces israeli. That's usually the one that we see, and they cause about 60 to 70% of the infections seen by Actinomyces. So I think a lot of people forget that they actually are part of the normal flora of our gastrointestinal tract, of our mouths, or the oropharyngeal tract, as well as the genital tract. So that's important for us. And if we break the mucosal lining, so if there's a tumor, if there's any foreign object like an intrauterine device, any type of foreign body, and you've got any damage from any cause, so even surgery, you can actually cause infiltration of these organisms, and they can cause an infection. What they normally do is they cause a granulomatous inflammation, and they end up causing abscesses as well as sinus tracts. So at med school, we normally get told about sulfur granules. And in general, Actinomyces causes about an infection in about 1 in 300,000 individuals, but that's normally the cervical facial Actinomyces, and a lot less likely to cause the pelvic or Actinomyces, which is quite rare. Your risk factors are diabetics, malignancy, anyone on immunosuppressive therapy, end-stage renal failure, chronic alcohol abuse, and as I mentioned, any surgery or foreign bodies such as IUDs, local tumors, trauma, so that includes your surgery, obviously organ transplantation, any immunocompromised individual, and obviously for the cervical facial will be your poor oral hygiene. So anatomical sites, most commonly your lumpy jaw, which we see quite a lot, and then less likely your abdominal, pulmonary, CNS. We do see cutaneous, very rarely in the joint and rarely in the genitourinary tract.
Tina,
yeah.
Sorry, I wonder if I can ask you, would you just expand on lumpy jaw?
Yeah, so the lumpy jaw, essentially what that means is that it normally happens in an immunocompromised patient. It's usually a poorly controlled diabetic with poor oral hygiene. It normally develops an abscess of the tooth that develops a granuloma with an abscess, and then they start getting sinus tracts and granulomas in the jaw. And because of the funny kind of lumpy granulomas that occur with long-standing disease, they often get this lumpy look with granulomas underneath the skin, basically, and osteitis as well as sinus formation. So it's kind of like a chronic granulomatous sinus lumpiness that occurs in a very non-scientific description.
Lumpy jaw.
Yeah, yeah, of the jaw. Yeah.
Lumpy jaw of the jaw.
Sorry.
Yeah, we got it. Thank you.
Yeah. Yeah. So when it comes to pelvic actinomycosis, it is quite a rare condition, and normally accounts for about only 3 to 5%, up to 10% of the actinomycosis cases. So we don't see it a lot, and most of those are actually related to the presence of IUDs. and can also be associated with bacterial vaginosis and presence of local tumors. As you can imagine, any damage or break in your normal lining. Usually what happens is that you have your epithelium that's invaded and eroded, and the patients can present with a mass. Initially, you can get low abdominal pain. You can get some abnormal vaginal bleeding and a bit of a discharge. Then some weight loss. Some patients can lose quite a bit of weight loss. So obviously with this abdominal pain, pelvic pain, discomfort, bleeding, often, you know, doctors will be concerned about a malignancy. It can imitate myomas, adenomyosis, any of the masses. And the reason why, you know, the actinomyces gets through is obviously because the breakage or the breakage of the epithelium, it breaks through the uterine lining. And it's thought that there's some sort of altering of the carbohydrate metabolism of the endometrial cells by the organisms. So we've got a couple of different clinical scenarios in the gynecology setting, and the ones that we often find is an incidental finding on a pap smear with or without an IUD in situ, and a patient with no symptoms. So somebody who's basically just gone in, they've had a pap smear, and now we've got actinomyces on a pap smear. So we'll go through all of these one by one. Secondly, a patient who's actually come in with, let's say, vaginal discharge, doesn't have an IUD but has actinomyces on a pap smear. Thirdly, patient with an IUD with symptoms such as a vaginal discharge with actinomyces on a pap smear. And then lastly, somebody who actually has come in with pelvic pain or a fever, perhaps has PID or tubo-ovarian abscess, or infection of any of the pelvic structures. So that's your fourth scenario. So we'll go through those one by one. Okay, so the first one, you've gone in, you've had your pap smear, we have a look in the lab. It's just somebody who's gone in for a screen, no symptoms whatsoever. We have a look and we see these little branching little bugs. Patient's got actinomyces, we report this. So obviously the pathologist gets a phone call. What do? There's actinomyces on the pap smear. So usually what we say is, does the patient have symptoms? If there's no symptoms, we reassure and we say, yes, you know, actinomyces is part of your normal vaginal flora. If the patient has no change in their discharge, is otherwise completely well, whether they have an IUD or not, they are symptom-free, which means essentially reassure the patient, tell them if they've got symptoms, they can come back and let you know. We know that about 7% of IUD users will have actinomyces-like organisms on their pap smear. Some of them will even culture it if you take the IUD out, if they've got an IUD, and it doesn't necessarily mean that you've got an infection. We know that obviously the insertion itself of the IUD can push the organism up into the uterine cavity. And this is a very slow growing organism. It doesn't necessarily mean that you will get an infection.
Tina?
So, yeah.
So, Tina, you know, we do lots of PAPs and we put in lots of loops. If you do a pap smear and it's an incidental finding, do you have to tell the patient, or because you're going to open a can of worms?
No.
Some people that are very
You can, absolutely. So, you know, I would, it's really up to you. You know, I would, the first thing I would do is ask them if they've got symptoms. If they've got no symptoms, I would follow them up as usual, say to them, you know, your next pap smear is due XYZ. If you've got any problems, come back and see me. You know, it is normal flora. So you actually you really don't actually have to disclose that, because it's not really a pathogen. You know, it's the same thing, I suppose, as telling somebody they've got normal strep pneumonia on their respiratory tract, and you've done an MCNS and you've got normal flora on your sputum. You know, whether we need to disclose that or not. We know strep pneumonia can cause severe pneumonia, but the patient's asymptomatic. So, yeah.
Yeah.
So,
Okay.
you know,
Thank you.
I think probably not. Yeah.
All right.
Okay, but once again, yeah, you know, obviously, some doctors, GPs will phone and they're stressing about it. So just, yeah, just to be aware, it's not like growing a gonorrhea where we know that it's pathogenic and needs to be treated. So just to be aware of that.
Yeah, you can run down a rabbit hole and then
Yes, you can. Yeah,
Yeah.
with patients that are very anxious. Yeah.
yeah.
Okay, so a different scenario, if you done a pap smear, we see the same thing, but the patient's got a discharge. So obviously now we need to decide, is this discharge because of the actinomyces? Remember that the patient in this case has no IUD. So the chances that they've got a discharge because of the actinomyces is probably quite low. You don't just get actinomyces discharges without a foreign body, or without any, you know, local tumors or anything going on. So obviously one needs to exclude a PID, go through a proper history. Does the patient have any pelvic pain, any abnormal bleeding, any weight loss, etc., etc.? And your workup would probably be, as a first case, a first port of call, I would probably do an NCNS. If it's a sexually active patient, one could do a STI workup in this case, see if there's a reason for the vaginal discharge. If there is, treat that, and then obviously follow up with your normal pap smears. This patient doesn't have an IUD, so the chances that this is invasive actinomyces is very low, and this could just be a red herring. So this one
Tina,
is,
So,
yeah.
sorry to keep interrupting. I
No,
get all
please
these
do.
questions.
Please
One of them
do.
is it sexually transmitted or is it not
No.
considered an STD? Not.
No, it's not considered sexually transmitted. No.
Okay, thank you.
Yeah. So
That
this
opens
one,
its own can of worms, you see.
yeah, absolutely. Yeah, absolutely. Yeah. So this is, you know, probably part of the normal flora. You've probably just picked it up. The vaginal discharge is much more likely to be something else. It's probably bacterial vaginosis. Your NCNS will probably pick up something else, maybe a candida, maybe a BV. You'll treat that and the vaginal discharge will settle. And yeah, so we always need to think of, you know, the commonest things happen commonly. And yeah, once again, don't go down a rabbit hole just because we've seen actinomyces on a pap smear.
Tina, I've got another. I don't want these questions to heap up. Erwin says, is it possible that the patients, for example, a woman that has a pap smear at Lancet, can they get their results directly from Lancet? Because if they do, that's where the results show actinomyces. You phoned and you say everything is kosher. They said, no, but I've got actinomyces. Why are you hiding something from me? Do you give patients their results directly if they phone or not? Or don't you know?
I do know. So, according to the POPI Act, it says that you know, your results belong to you. So, what happens is the patients have access to their Lancet portal, and they can access their own results with their ID numbers. So they do have access to their own results. But what happens is we have I think a 72-hour hold on those results. So what happens is it allows the physicians to access the results first, to obviously before the patient gets them. And then obviously we will never allow patients to get histology results where there might be cancer or HIV results, you know, things that are concerning.
Okay.
Yeah, so those go to the doctor's own. Yeah.
And just quickly, someone says, what is the difference between actinomyces versus actinomycosis?
Oh, okay. Yes, thanks for that question. So actinomycosis is essentially the disease that is caused by actinomyces, which is the organism. So it's actually the same thing.
Thank you.
Thank you. Thanks for the questions. You're welcome to interrupt me at any stage. Okay. So the next one is a patient who's got an IUD and has got symptoms. And what are we going to do now? Okay, so once again, we are concerned, is the discharge because of the IUD or is it not because of the IUD? So we've had a couple of cases like this as well. So normally what we do is basically, we need to follow up. Does the patient have any other symptoms? Do they have a fever? Do they have pelvic pain? Have they lost weight? And we need to essentially exclude invasion of pelvic structures, tuber-ovarian abscess, any invasion. If they don't have any of that and they only have a discharge, what we often do is we can basically send the IUD for a culture. And if it cultures, we could then treat for 2 weeks with penicillin, TDS. So that's also a contentious issue because some people actually just remove the IUD, watch and wait, and if the discharge goes away, then they leave it as that. Other people will treat for 2 weeks and essentially, hope that it hasn't invaded any further. Often, if there's no other symptoms, it's unlikely that it's gone any further. But the concern always is that the IUD is infected. The only way to find out whether it is or isn't is actually to culture the IUD itself. But obviously, in saying that, we know that normal patients without symptoms have cultured it as well. So, unfortunately, there's a bit of a gray area as to, whether or not this is the right approach, because once again, one can take the viewpoint of, is there something else causing the discharge, such as a candida or a gonorrhea or a chlamydia, etc., etc. So once again, every patient can be followed up. It all depends on how much you want to save that IUD. Can we do it in a stepwise fashion? Absolutely. We can exclude any other causes of the discharge. Once you've excluded other causes, then we can decide on removing the IUD and see if that actually then settles the discharge or not. Obviously, if there are any other signs of invasion, PID, etc., then we need to follow the invasive protocol, which I'll show you on the next slide. Are there any questions?
For now, we're good. Thanks very much, Tina.
Okay. All right. So yeah, these are all my little flow charts, because I try to sort it out in my own head in terms of what I would do. So yeah, there's very, very little literature as to what everybody does, and everybody seems to do something different. So I thought I'd just write it down all on a piece of paper and put it all in a little graphic form to make it easier. Okay, so invasive disease, usually weight loss, vaginal bleeding, fever, pelvic pain, sometimes you feel a mass, etc., etc. So that is usually quite advanced, often misdiagnosed. And a PID, obviously, is not always actinomyces alone. Often we need to treat it as a PID with, for the anaerobes, for the gram negatives, for all the organisms that cause PID. So that would be your normal protocol. Doxycycline does cover actinomyces. So that protocol is obviously, if you would know that, for the 14 days. It's interesting because some people actually, although it's invasive and although actinomyces is generally treated for very long, if you're looking at a cervical facial, I've seen some literature to say that they treat for 14 days and then watch and observe. However, other publications say whenever there's an abscess, an invasive disease, and you haven't done a proper debridement, surgery, washing out, etc., etc., it must always be treated for a couple of months. And that is because we don't know how far and how extensive the disease is. So, it's all, from what I can read in the literature, it all depends on how the patient presents, how extensive the disease is on your MRIs, on your CT scans, how extensive your surgery is, how extensive it is on the invasiveness is on your histology, etc., etc. So it all really depends. So it has to be a discussion between the surgeon, the microbiologist, the radiologist, and the pathologist involved. But generally, with abscesses and invasive disease, we start off with high-dose intravenous penicillin, and that's 3 to 5 million units every 6 hours. We usually use that for the first 2 weeks. If the patient is not responding and they're quite severe, we we can keep that up to 6 weeks. And then that we de-escalate to oral penicillin, where we give 2 to 4 grams daily in divided doses. For mild infections with not a lot of fistulas and sinus tracts, you can treat mild disease for 2 to 6 months. And in what they call classic forms of actinomycosis, which is the pulmonary, abdominal, and the cervical facial, they treat up to 6 to 12 months. And the reason why they do this is to prevent disease recurrence. I have seen this strategy used as well for some of the pelvic actinomycosis. But once again, I also have seen shorter courses. So I don't think there is really a kind of exact protocol. But once again, I think it needs to be tailored based on your patient, how long they've been sick, the extent of disease, the surgery that was performed, etc., etc. But I think surgical intervention is certainly very important. So my last 2 slides are a case report, just interesting because I wanted to just show you how these people did it. This was from the American Journal of Case Reports. And they presented a 54-year-old lady who had bilateral lower abdominal tenderness with lack of appetite and vomiting for 3 months. They found a pelvic mass a month before her admission, and she had quite a lot of abdominal pain for a few months and constipation. She didn't really have much abdominal distension and had no vaginal bleeding. Apparently, she had an IUD for many years, and it had been removed 6 months prior to her presentation. She lost 15 kilograms of weight loss, which is quite suspicious. So they were worried about a malignancy because of her age. She had a normal CRP, and her hemoglobin dropped quite dramatically over the last couple of months, which was dropped to 7. They performed an ultrasound, which showed quite an irregular pelvic mass. I have not seen an MRI for years, so I put that picture in there, but I wouldn't even be able to tell you what's normal and what's abnormal, so I leave that to you.
Tina, that MRI picture is back to front. You just must make a note of that.
Oh, did I? Oh,
yeah.
Okay. Well, there we go. A microbiologist showing you radiology. That shows you.
Back to front.
Okay. All right. And then, so they confirmed a pelvic mass. And then they performed the surgery, which showed a couple of adhesions and quite an inflammatory mass, which showed under the microscope a lot of gram-positive bacilli, relatively well circumscribed with a lot of peri-mass inflammation. They fully removed the mass, and they actually only treated the patients for with high-dose penicillin for 14 days. But what they did is she responded really well, and they followed her up for a year with symptoms, and she had absolutely no symptoms after her 14 days of penicillin and removal of mass, which they said was quite contained with no sinus tract or fistula. So I was quite surprised they didn't treat her at all with follow-up oral antibiotics, but she had no recurrence. So this is just an example of, you know, how they did it. And they specifically did mention that they acknowledge the fact that many people would have treated her for 6 months, but they decided that she responded quite well and her lesion was quite localized, and that the treatment was based on the patient's specific scenario. So that is all I have for you. And those are my details if anybody wants to get a hold of me, or you have any interesting cases to discuss, or if there's anything that I can help you with. Thank you very much.
Thank you so much, Tina. Can I just do 1 or 2 questions?
Yes, of course.
One of the questions is, where does one, they say catch, but I'm not sure if you catch actinomyces or endomycosis. Where does it come from? This seems to be quite a fastidious organism, and how does it arrive?
So, one, I suppose, could say that for all of our normal flora, I mean, babies are not born sterile. We acquire our microbiota from our parents. And
Okay.
as we grow, we get exposed to the environment. So food that we eat, everything that we are exposed to, food, vegetables, soil, water, that all we get exposed to, and it inhabits our mouths, our guts, and our genital tract. So it basically lives with us. So it's one of those bugs that actually is living as part of our own flora. So it's
Okay.
not that we really catch it, it's part of us, as with
Okay.
viruses and everything. Yeah.
So it's like skin to skin contact, perhaps at birth, and it lives
Yes,
with
and
you.
probably eating. We probably eat Actinomyces from the soil and from the ground. Yeah, and
Yeah.
in the water, I would think.
Yeah, that's an interesting question. Just as an aside, I did a ward round this evening, and there was a newborn child being cuddled by his father, and the father had on his right hand a glove, and the child was sucking the glove, and I said to the father, "Why on earth are you wearing a glove?" He said, "No, the lactation consultant said he had to wear a glove," and I thought,
Oh.
well, very strange advice.
That
So
is odd, because he should be being exposed to everything, because that's how your immune
exactly,
system
skin to
develops.
skin contact, and then acquiring a gut
Should
biome and a
be.
flora is
Yeah,
how.
I mean,
Yeah.
unless you're severely immune compromised, where pathogens can affect you. I mean, I believe children should be licking dogs, licking floors. That's
And
my
eating,
feeling. Eating
not
poo.
eating dog poo. It is, yeah, that's
They
interesting.
should. They should.
They do, and that's why they have antibodies, because that's where they acquire them from, I
Absolutely.
guess.
That's how you develop, that's how you get immune tolerant, and that's how you prevent your autoimmune diseases and your you become, and your allergies.
Do you have a specific interest in the gut biome or
Yes, I do.
microbiomata? You do.
I do. Yes.
So you might do well to read the JAMA article on.
I will. Thank you. I must look
Yeah.
at that.
Tina, it's been wonderful having you here this afternoon. I'd like to thank you very, very much indeed. It's
Thank
a
you.
great number of people have logged on. And
It
also
was
I'd
an
like to
absolute
thank,
pleasure.
it's been wonderful. And of course, thank Lancet for giving you the time off, and also Metagenic
Absolutely.
for sponsoring this session. Just to remind you that next week, at the same time, same place, we have Renato Lawrence, and he's speaking on surgical updates on placenta previa and placenta accreta spectrum syndromes. So that's going to be something else for the histology and for the obstetricians amongst us. It's been wonderful to have you over here. Steve is going to give the final thank you. Steve, would you like to say a final thank you to Tina?
Yes, Tina, thanks so much. It's been wonderful having you on. For those of you who don't know Tina, she's a great person to know. If you've got, sometimes you get a funny little bacteria on even your urines and things like that. And it's great to call her, and she's available.
A bacterium on my urine.
Yeah, I mean, you get a result that you just don't quite know what to do.
I see,
Even on a Saturday or Sunday morning, you can call her.
Please WhatsApp me. I always have my phone. I love my phone. I have fun on it. So please WhatsApp me anytime.
But I look forward to the next talk about the microbiome, eh?
No,
Yeah.
yeah, the next, but Michael, we'll give you a ring on that. Chris is on
Whenever you need me. Yeah.
yeah. It's
Thanks so much for the lovely words. Thanks.
It's a fascinating topic, and we look forward to hearing that. Just to remind you that if you haven't yet registered for FIGO, which is in October, the early bird registrations are closing soon. So remember, if you get a group of your pals together, you get up to
30.
Yeah, don't you know 30 people, Steve? How many friends have you got? Anyway, so if you get 30 friends, if you got 30 friends, Steve, you get a 25% discount. And that's a hell of a big discount. 25% discount on your registration fees. So Steve, I urge you, if you do have 30 friends, to phone them and call them and get that discount. 25% is a lot. If you only get 15 friends, you get something like a 10% discount. So it's a pro rata.
For everybody or only for you?
Now for everybody.
Oh,
So
okay.
it's worthwhile logging on to
Well,
FIGO.
there's 74 people on still this call, so maybe we can all talk.
Oh, well, there's 74 people get together and you can all come to Figo at the CTICC right next door. Tina, I think it's been wonderful having you over there.
Lovely
Can
to
I-
see everybody.
Tina, let me ask you, do you have any children, if I may ask?
I don't. No, I've got 2 cats though.
You're not scared of their
yeah.
microbiome
No, I
confounding?
kiss them all the time. They lick
You do?
they lick my bowls. They
lick
yeah,
your
I'm
what?
trying to they lick my bowls and my
Bowls.
plates, and yeah. I've got a very healthy microbiome.
Okay, you're not scared of getting cat scratch fever or
No,
what's that other thing they get?
no.
from cats?
Okay, well, thanks very much. It's been wonderful.
Thanks everybody.
And we look forward to having you again,
Yeah.
Tina. It's been wonderful.
Thank
See
you
you
very
much.
soon.
And
Thank
all the
you.
very best.
Bye.
Safe home, Tina.
Okay.
Safe
Bye.
home.
Bye. Thanks, Chris. And,
Okay, Chris.
Belinda, bye.
Thanks,
Thank
Chris.
you.
Bye.
Bye.
Thank you.
Bye.